Happy Thursday, everybody. Good to see you. I'll give you all a minute to get connected. I see we're all getting connected, getting your videos up. It's good to see your faces. I'm very excited to have you all joining us today for this conversation. I'm Anissa Mitchell with PMD Alliance. And this program today is the first part of a three-part series that we're doing in partnership with Medtronic. We're going to be looking at DBS from a different lens. This is more on the impacts, quality of life, demystifying some aspects of DBS, and how it really does impact people through this route of treatment. Today, we're going to be focusing our conversation around what DBS is, how it really can help a person in their life, how it might change them, answer some of your questions. And then our following programs, we're going to be talking a little bit about the prep of getting vetted for the surgery, who's going to be a good candidate, what does that whole process look like? And then we're going to be hearing from a movement disorder specialist, as well as somebody who's gone through the surgery. And then in January, we're coming back for the third one. And this time we're going to be talking about the use of DBS for both Parkinson's, essential tremor, as well as dystonia. So today we have with us Dr. Francisco Ponce. He's a board certified neurosurgeon. He serves as the director of the Center for Neuromodulation and Neurosurgery Residency Program. He's the chief of stereotactic and functional neurosurgery at Barrow Neurological Institute in Phoenix. And his expertise is in deep brain stimulation and surgery for Parkinson's, essential tremor, and dystonia. And then also joining him today, and it's going to be adding to this conversation, is Meg Lambert. And she is a senior field marketing development manager for Medtronic. And her role is multifaceted. She's responsible for building therapy awareness to patients and referring physicians, and ensuring that people understand and can benefit from Medtronic's deep brain stimulation. And before that, before joining Medtronic, she actually worked with Dr. Ponce for almost a decade. So they're kind of happy to be back together in this role, where she was the program coordinator at Barrow Neurological Institute. That's a lot of words. And so I'm happy to have this conversation with both of them. So welcome to the both of you.
Thank you.
Thanks for having us.
All right, and then throughout this conversation today, we invite you to go ahead, open up your chat box. That's where you're going to ask your questions. So as we go through the conversation, we'll be going through some of those questions. So if you want to give us a shout out, let us know where you're joining us from, and then that's where you can ask your questions. We'll kind of try to go through those as we have our conversation. So I want to kick off this conversation with Dr. Ponce and Meg first to give us a general overview of DBS. Like, what are the symptoms that DBS actually addresses?
Yeah, so DBS is a medical device that's used to treat Parkinson's and tremor. It's been around for decades, and the way to think about it is that it's an electrical therapy, just like a neurologist may use medications to improve control of symptoms. When medications stop working as well, electrical therapy is incredibly effective, been time tested and proven to be safe and effective. And so the use of this is, it's like a neurologist. When you're under the care of a movement disorder specialist neurologist, your hope as a patient is for them to get you optimally controlled with your disease, so you don't have to think about it each day. And they have tools in their tool chest, up their sleeve, to help you get there. And when they start running into walls with medications, this is a therapy that's there. It's been around, but the thing is, not all neurologists reach for this. And so you may be dealing with, taking more and more medications a day, dealing with your symptoms breaking through, and not know that what you consider is becoming your new normal is not the new normal. The normal has been already established with things like DBS that can minimize your symptoms. So the good way to think about which symptoms it controls it controls the same symptoms medications control. So primarily, we think about tremor, stiffness, we call it rigidity, and slowness, which is bradykinesia. And those three cardinal features, it's like shuffling around, not being able to move, not swinging your arms. Those are the three cardinal features of Parkinson's. Those are the features that respond to Sinemet levodopa based therapy, and they're the ones that respond to medication. And those are the ones that also respond to DBS. So it's those same symptoms that respond to medication. In fact, to be a good candidate for DBS, you should have demonstrated a period of time, you usually think about 4 years of good medication response, and then at least 4 months of dealing with complications. So in short answer is, it treats the same symptoms, the motor symptoms that medications have worked well with, but is used when medications stop providing consistent control. So thinking about it like a pacemaker, there's the device. You can see it in this picture right here. It's like the pacemaker is placed in the chest, similar to a heart pacemaker. And then you see those leads, and those are placed into the brain about 4 inches deep to the skull, basically to a part of the motor circuit that if you pace that node, it can reset the misfiring that occurs in that motor circuit that causes the symptoms. Okay, we can take that slide down.
Awesome. All right, so you did review some of those symptoms. So age-wise, is there like an age range or time that somebody's had Parkinson's that makes them a better candidate?
Amongst clinicians, we often think, younger and earlier is better. So we want to make sure it's Parkinson's disease, not some other condition that may initially look like Parkinson's, but then evolve to be something different. And medication responsiveness is a very useful tool to tease out true Parkinson's disease versus Parkinsonisms. And so some patients, it's pretty obvious, some tremors don't respond to medication. Those tremors, if they're Parkinson's tremors, will respond to DBS. So we do have a number of patients who've been diagnosed for 2 years, but sort of the home base is 4 years of medication responsive motor symptoms and at least 4 months of kind of going around in circles trying to chase those symptoms because the original medication regimen is not as effective anymore. Age is a relative term in this day and age. We've got, it's like 80 is the new 60 or something. I mean, we have a lot of patients in their 80s getting DBS. It's a matter of really just looking at their risk profile, their health, talking to their family, making sure the expectations and the goals match. But I have patients in their mid 80s who are like, I plan to live another 10 years and I don't want to live like this. And so we kind of go through it carefully, but there's not a strict age cutoff. I think it's more health-based than age-based.
Yeah, I think the oldest patient you ever did was a 92-year-old gentleman who had essential tremor.
Yeah,
and he was in excellent health, cognitively intact, sharp as a whip, and his tremor just got in the way. So yeah, he did real well.
Yeah.
And, you referenced the medications. So someone who is having a lot of motor fluctuations, dyskinesias, can you speak a little bit about that? Because I know that that is something that sometimes people get confused off, the dyskinesias and how DBS might be impactful in that way.
Yeah, so we talked about kind of the 3 main symptoms that respond to DBS, the motor symptoms, stiffness, slowness, and tremor. And then the 2 kind of cardinal side effects of medication are motor fluctuations and dyskinesias. So motor fluctuations are when there's a time of the day that, after, right before lunch or something, you become stiff again, or you start to shake again. And you're good for a couple hours after breakfast. But every day this comes in, I know it's time to take my pill. And that is not, you don't have to accept that. That doesn't have, that's not inevitable. And, when you think about diabetes, you're expecting your blood sugar to be controlled 24/7, with your regimen. Same thing with allergies, right? You take your 24-hour allergy. I take Claritin every day. Same thing with high blood pressure, right? You're not expecting these breakthroughs, these spikes. And so this is something that, again, people may think it's the new normal is dealing with their symptoms periodically during the day. And in the process of trying to optimize control, they may be taking their medicine every hour and a half even. I mean, 7 times a day. I have a number of patients who come in, take their medication 7 times a day because they're chasing these symptoms. That's due both because of the fluctuations that can be the way the medicine is absorbed into the gut and then transported to the brain. And the other one is dyskinesias. And dyskinesia, it's squirmy, kind of ants in the pants, squirming around in people's chairs. And it's something that often can even be more troublesome to those around them than to the patient themselves, because the patient would rather be squirmy than slow and stiff. So they actually, it's a reflection of medication overdose or medication oversensitivity. And so you can, through DBS, you can reduce dyskinesias either through reducing the medication requirements. That's a very kind of established benefit of DBS, that you can lower the medications. Or there's another area of the brain that we use for Parkinson's, where regardless of what we do with medication, we can reduce that oversensitivity to medication. We can by reducing dyskinesias. So those are kind of like 5 things I think about: tremor, stiffness, and slowness, and then dyskinesias and motor fluctuations. That's kind of like home base in terms of what to expect from DBS.
And can I describe motor fluctuations a little bit? My dad had Parkinson's, and we used to call it Daddy's roller coaster day. He'd get up in the morning, he'd take his pills, he'd wait till they kick in, and then he knew he had about an hour and a half where he could do things around the house, and then it would drop off. Then he'd have to wait again. And it's the roller coaster day. And that's what Dr. Ponce was talking about, motor fluctuations. You don't have to live like that. DBS can almost make it like this. I have patients that tell me they forget to take their afternoon dose of medication once they've had DBS because they feel so consistently good throughout the day.
So I had a question about how long the surgery lasts. Like if I had DBS, how long can I expect to benefit from it? I know that there's adjustments that occur. And I want to relate that to a question about those who have young onset. So somebody who was diagnosed at age 35, if they then ended up like at 37 or 38 getting DBS, how long can they expect to benefit from DBS?
So DBS will last the rest of your life. It does not change the course of the disease, like what's happening in the brain doesn't stop. But just like tremor or stiffness or slowness will remain a problem through the rest of one's life without treatment, DBS will always help with those symptoms for the rest of one's life. So that scenario of the early onset, it's not like you're using a tool now and it's going to be less effective 10 years from now. So why don't I wait 10 years so that when things are more severe, I can use it then. If anything, having it done earlier will allow you to kind of partake in the fruits of life more during those 10 years by not having to think about medications as much, not dealing with the breakthrough symptoms during the day. And so kind of stabilizing that quality of life and the social element of living more. So you haven't, in 10 years, you can adapt to this new sense of self as somebody with Parkinson's whose symptoms are poorly controlled. And that's a psychological adaptation, not just a motor deficit, but a psychological deconditioning. So this will last the rest of one's life. Later in Parkinson's, there are different symptoms like cognitive impairment that become impairments to quality of life, that affect quality of life. And so if there is a window in Parkinson's for DBS, if it's too early, maybe we're not sure about the diagnosis. If it's too late, then the stiffness, slowness, and tremor, those motor features have almost take a back seat in terms of impairment to other problems that develop later in the disease, like cognitive disorders like dementia. So it will last the rest of one's life. People who are dealing with dementia, who have batteries, who have DBS from earlier, when the battery stops, people think they need to go to hospice, like they look horrible. And then if their battery dies, and we take them to surgery, we switch out the battery and they're walking out of the hospital. So even though those patients may not be candidates anymore to undergo new DBS, the system is still life-changing for them, even as they're dealing with newer and later stage problems of Parkinson's.
So I want to flip that. And you said that doesn't speed up progression of the disease? Can it actually have a positive impact on disease progression? Is there any indication of that?
It won't speed it up and it won't slow it down. No, I think our home base is just the brain's going to do what it does, and we just kind of do things to kind of control the symptoms and make life better. But at some point, it's if we all were to live to 150 years of age, we'd all have Alzheimer's and we'd all have Parkinson's.
So I want to get into some of the quality of life aspects of it because we keep referring to it, but maybe before we could talk a little bit about the actual surgery and just kind of get that out of the way, because I think that is something that kind of scares people. So can you walk us through a little bit about the surgery, what to expect? And I did have a question. Someone wanted to know if other issues could keep them from having it, like an autoimmune disorder. Are there things that would disqualify somebody from a medical perspective that they should be aware of?
The main thing I encounter would just be somebody who's so dependent on blood thinners that it's extremely dangerous for them to get off blood thinners, that the risk of something catastrophic would get in the way. I think if you're frail, if you've had a quadruple bypass and you got stents and a ostomy bag, and if your whole body is kind of already on the brink, DBS, going through any surgery could push you over the brink. So that's kind of the operation itself. It's done in 2 stages. So you put the leads, so the 2 holes are done behind the forehead, and the leads that were shown in that image go about 4 inches deep, and then they're tucked underneath the scalp, so you can feel a bump underneath the scalp. A couple weeks later, come back, and 2 new incisions are made, one in the chest for the pacemaker, and one kind of behind the ear for the connection between the brain leads and the neck wires. And for the first operation, you're in the operating room for about between 2.5 and 3.5 hours. The operation itself takes between an hour to an hour and a half. And for the second operation, for the battery, that takes about 25 minutes. So you're in the operating room for maybe 45 minutes to an hour. And the first operation is brain surgery. And you spend the night, at least one night in the hospital, and the second one is outpatient. You go home same day. And so far as mitigating risk, we have new tools at our disposal now that we can really evaluate whether somebody has been taking a blood thinner even though they don't know it, right? We've identified patients who are taking aspirin, but they're like, I don't take aspirin. It's like, well, your blood tests show that the aspirin pathway is completely inhibited. So that's been one way to kind of reduce, because we screen patients for risk, and sometimes when things happen, we look back and we can see abnormalities that don't match the history we're given. So those are ways that really kind of streamlining the operation to avoid infection, using intraoperative imaging to verify where we want to be before we leave the operating room. All of those are trying in an effort to really standardize and streamline this operation that people seek out for quality of life.
And prior to surgery, if the patient is under the care of a specialist, whether it's a hematologist, a rheumatologist, a cardiologist, they are always contacted prior to surgery to see if there are any risks that they are concerned about or any special medications they need to take prior to surgery. So that is a given. Those specialists are always contacted prior to surgery.
And we had a question about the staging of adding the leads. So maybe doing one side first and then waiting to do the other side. Can you talk a little bit about that? What's the benefit of doing it that way versus implanting both at the same time?
So the amount of time required to that second side is relatively trivial. It's like 15, 20 minutes, depending upon where you are, it's a surgeon, whatever the surgeon's routine is. And the risk is probably relatively small too, especially because that second side is usually the non-dominant brain. If you're right-handed, the second side would be for your left hand. And that would also be the side that's not involved in language. So I think at least 95% of the surgeries I do are both sides at once. I think it's a style maybe by the neurologist. The neurologist is kind of like your guide. And during that journey with Parkinson's, the surgeon is a point in time in your overall journey. And what the surgeon does is it helps the neurologist deliver a therapy that they know is effective and is proven, but you need to see me in order to get that. And so and some neurologists, some neurologists don't like surgery, and some may feel more comfortable saying, look, let's just do one side, and you can go back and get the other side. For me, I think a patient is better off seeing me, get in, get out, and get back in the game, and not have to be tethered to seeing me for all this stuff. Because again, the intention is to equip the neurologist with this therapy to complement what they do with medicine. So the staging is really, I think, neurologist dependent. Because of Parkinson's is bilateral, and patients who get one side will most likely come back within a couple of years for that second side. And if that's kind of how they and their neurologist kind of want to approach this journey, that's totally fine. I know from the perspective of the hospital, for hospital reimbursement, a model where you can actually switch, if you want to have both sides treated, you can have 4 surgeries to do this. You can have 4 separate events. One side, one battery, the other side, the other battery. And from a hospital finance point of view, that's probably the most advantageous strategy. So, so we got to kind of be realistic in the United States in terms of how insurance has kind of done this. And the way I've kind of settled on is do both leads and then come back and do one battery and connect everything together. So that's 2 surgeries. But there are places historically that have broken this into literally 4 separate trips to the operating room. And that's driven more, I think, from hospital reimbursement because they can't do it in a financially viable way otherwise. And then after you realize that financial necessity, then you kind of backtrack and create a narrative for why that's in the patient's best interest, but so that's 2 sides of the coin that I consider when looking at, single versus 2 sides of the brain.
So someone wanted to know if you could explain a little bit about the entry into the brain when you're doing the surgery. How actually is that done?
So it's kind of like it's this little cylinder that turns, and we core out it's less than the size of a dime, a little hole right here. And so that's how we make the hole. So it's an incision that goes behind the forehead, and then a little hole that I've actually put a little cap over. And that's not in the pictures, but so you can feel the bump underneath your scalp. And so 2 holes, and then basically I have surgical tools that are made to enable me to be a sharpshooter. So I pick where I want to go in. So the reason we go behind the forehead is it turns out the brain right in that area is not super sensitive. So if there's any swelling or even a little bleed, it may slow things down. You may have a little bit of confusion or speech, but it gets better. And then you get back to where you were before. And so that's why we go where we go. We enter because that's a safe place to enter. And then we get, 4 inches deep, and that's where we get into the nice, sweet motor circuits. So I pick where I want to go. I will pick how I want to get there, ensuring safety. So some people will it'll be asymmetric. One incision will be in front of the other, and that's because their brain's not symmetric. And so we pick an entry point that's safe, make a small hole about less than the size of a dime, and then use a surgical instrument that kind of lines me up so I can hit my target within 2 millimeters. And that's how the brain operation is done.
And earlier there was a question about the leads. Do those ever have to be replaced?
No, it's rare that there's hardware damage. We can check the circuits and see if there's any short circuits, open circuits. That ties into MRI, qualification. In general, when I put a lead in, I'm never planning to touch that ever again. It's the brain operation. You have a little bit of scar tissue again in that area that's not as sensitive, but manipulating that could cause a seizure. So we don't willy-nilly. It's a very safe operation, proven, supported by the FDA and Medicare, but I still take a there, but for the grace of God we go approach in terms of, let's not think that we can just get in and get out again, scot-free. So I don't think that the risks of replacing leads justify the benefit unless there's a really clear deficiency in the current therapy. So the short answer is no, the plan is to leave those for life. We don't exchange those.
And can you have the pulse generator? Can you have that if you have a defibrillator or a pacemaker?
Absolutely. In fact, Medtronic's new system has a sensing capability that you can actually listen to the brain waves. And so we've been putting those instead of on the left side where the heart is, we've been putting those on the right so it doesn't the signal of the heart does not interfere with the sensing capability of the device. So as long as they're on opposite sides, you can have a defibrillator and a DBS system.
And we had a question, and I think this is important because this helps to kind of demystify this a little bit. Does the body ever reject the equipment? Have you ever had that issue?
I think Meg's fielded that question so many times.
I have. Dr. Ponce has done what, 1,400 patients? We've had no rejections.
Okay,
None
that's
out of
good.
1,400 patients.
They used to have a skin test that you could take to your allergist to kind of test to see if you're, and they stopped doing that just because it was.
I did one of those a couple of years ago. We had a patient who was allergic to everything. I mean, everything. When they changed a medication on her, they had to hospitalize her to see if she reacted. That was just basic Parkinson's meds. So we were a little, cautious with this individual, and we did the skin tests on her, and she was absolutely negative.
That's good.
Yeah, but 1,400 patients and no allergic responses or rejections.
And one person wanted to know if this is reversible.
Yes. So the biggest strength is the biggest weakness. It's the reason why you need the pacemaker, the reason why you're getting an implant is actually because it's adjustable, it's non-destructive, it's not an ablation, we're not changing your brain intrinsically, and it's reversible. So just like if the battery dies, your symptoms come back, that's a strength, but it's also why this is not a cure. If a cure to appear, or if gene therapy or stem cells were to all of a sudden be proven to work, you'd still be a candidate because the intrinsic circuits have not actually been changed. DBS replaces ablative surgery. DBS replaces going in and making a lesion. And we still have technology today that's becoming increasingly popular, where with focused ultrasound, without an incision, you can have treatment for movement disorders. What people often don't appreciate fully is that focused ultrasound results in a lesion. You're actually destroying a part of the brain. And what you see is what you get. You can't adjust that. You can't optimize it. And the tendency is to undertreat with these therapies because you can always go back and make a bigger lesion, but you can't give back brain that you've destroyed. So this is reversible, and that's why you need the pacemaker. That's why you have the pacemaker there.
Right. And how often do those batteries need to be replaced?
The rechargeable batteries last 15 years.
years.
And Meg, your experience with the non-rechargeables, what have you seen?
Well, we say Medtronic says the batteries will last for 3 to 5 years, but it depends on the stimulation that you're receiving. For example, if you're set very, very high because you have severe symptoms that have to be controlled, you're going to burn through your battery a little bit quicker than somebody who has lower stimulation parameters set into their battery. Does that make sense? So 3 to 5 years, but I want to say on average, I would say 3.5 years to 4 years.
Yeah, and I think
is the average.
We're seeing the new Medtronic Percept PC has some new bells and whistles, and I think
it's going to last a little bit longer.
We're hoping to see it'll last longer. Yeah.
So I want to spend a minute talking about that because that goes into, it leads nicely into the quality of life. But can you talk about after the surgery is done and we're now starting the programming, like, can you talk about this system offers and how that's a benefit to people?
Yes. In terms of the new Percept battery that is out, it is a major tool to the movement disorder neurologist who is doing the programming because we're able to capture, like Dr. Ponce described, those waves in the brain, and it shows us when a patient is tremoring, when a patient's having dyskinesias, when the medications are kicking in. So it's easy for the neurologist to make adjustments to the stimulation based on what they're seeing in the battery. Also, post-operatively, we always caution our patients and say, please be patient, because the best method of doing programming initially after surgery is go low, go slow. You don't want to hit the brain with a whole lot of stimulation right off the bat. You want somebody to recover. So most neurologists will set up different sessions. So maybe they'll do it every 2 weeks for the first month, and then maybe once a month for the next couple of months. It depends on the neurologist, but you want to go low and you want to go slow. And it also depends, your outcome initially is going to depend on where in the brain that lead is placed. For example, there's an area in the brain called the STN, or subthalamic nucleus, and it's a tiny little area, smaller than my pinky nail. Now, if you're going to stimulate that tiny little area, you're going to get more of a response early on when you start programming than someone who has it placed in a different area of the brain that has a lot more real estate. And we say that the stimulation has to basically saturate the brain tissue and marinate in there before you get more of a response. So we always tell patients, give it about 6 months. Give it a good 6 months to see a really good result. But again, some people see results, especially with tremor, right off the bat after that first programming session. But it just takes a while, and every single person is different. We say if you've seen one Parkinson's patient, you've seen one Parkinson's patient. So programming could take a little bit of time to get it perfected for you. So just be patient.
And I just had a question. What's the time between the surgery and the programming?
Well, that depends on the individual neurologist. Some neurologists like to, there's one neurologist that we know quite well that likes to start immediately after the battery's been placed. Some neurologists wait a week or two. Some neurologists, I've heard, wait a month or even more to start the programming. So it depends on the individual practices.
All right, so I want to get into a part of this discussion that we don't always get to cover in some of these live streams, and that's some of the quality of life aspects of having DBS. We are going to hear in the next program from somebody who's actually had the surgery, but from your experience, from the two of you, I would love if you would share a little bit about some of the improvements in quality of life that you've seen in people. And I know some of the questions that's coming in goes with some of that, and that's like, how can it help in terms of all of those medications? And you referenced it before, but what do you see in terms of not being so tied to that pill schedule and some of those other things that really help improve people?
Well, after surgery, many times patients can have their medications reduced. So that is one quality of life plus for patients. But I have to tell you, there's a variety of things. Everybody's value or everybody's personal quality of life is vastly different. So you have to look at it on a case-by-case basis. For example, I had one patient report to me that he was so happy after DBS. And I said, well, tell me what's changed for you, Joe. And he said, I'm embarrassed. I said, no, come on, I'm a nurse, tell me. And he said, I can now get out of bed by myself at night, go into the bathroom, and go to the bathroom and get back in bed without having to wake my wife up. And people have reported that they sleep better because they're not stiff, they're not slow, so they can get in a more comfortable position. I had one patient, she was socially isolated for the longest time because of her tremor. And after surgery, she came in here, she looked 10 years younger. And I said, how are you? What are you doing? And she said, I joined a card club where I live in my community. I can go out and I can play cards because I don't shake anymore. So quality of life is individual, but it is just so impactful when you see these patients several months after surgery and they report to you what they're able to do now and how happy they are. I had a woman come in one day. Her husband was one of those reluctant patients. It took him 2 years to make up, you know who I'm talking about, 2 years to make up his mind to have surgery. And once he did, he came to the office for a post-op visit, and his wife threw her arms around me and said, "Thank you for giving me my husband back." And I still get a little tearful when I tell that story. So things that we look at after surgery, and many times patients are asked these questions. How is your mobility now? What kind of activities of daily living are you now able to do? How do you feel emotionally? Are you happier? Are you less depressed because you're able to go out now? How is your communication? Because sometimes when people are slow and their speech is slow and they have a little more oomph, they're able to communicate more, or they're able to communicate in a social situation because they don't feel like they're just sitting in the corner not participating. The other thing is bodily discomfort. That's something we hear about, especially with Parkinson's patients and rigidity. I mean, when you have that cogwheel, when somebody's arm is just so stiff, that's one of the major things that's reported back to us after surgery, is that bodily discomfort basically goes away or is much, much improved. So there's a variety of things that patients report to us that they can do. We had another gal, and this really struck home to me because I'm a grandmother. She said to me, her tremor was so bad before surgery, she couldn't even feed her granddaughter a bottle, her baby granddaughter. And after surgery, she could. So it's those little things that are important to you as a patient that you have to think about. Where's your quality of life today? Where do you want it to be in a year, 2 years, 5 years, 10 years? What are those things in your life that are important to you? And how can DBS help improve that quality of life for you? Does that help?
Yes, I love that you share some of those stories too, because that kind of shows you some of those quality of life impacts. And some of the things that you said really made me think about, the reduction of isolation and maybe even some of the stigma that people might feel because of some of their motor symptoms, that now they feel a little more comfortable going out and feel better, and they functionally can get out and do things, and how that just can really help them. And while it may not have a direct impact on disease progression, if someone feels well enough to engage in exercise and socially engage, surely that has a positive impact on their whole quality of life.
And as you know, studies have shown that exercise is one of the best things you can do if you have Parkinson's.
And I imagine that there is a correlation to reduce stress in the care partner. I know you sort of mentioned that when the person came in and gave you a hug, but do you have any other stories that you've had care partners that have said, we're able to do more, the stress is a lot less, that you could share?
Yes, the partner of the woman who joined the Bridge Club, he was ecstatic. He said the fact that she was able to go out and they could go out as a couple and do things together was remarkable for him. We've had patients report that they now feel that they're not tethered to their home because their partner who underwent DBS is a lot more self-sufficient with just activities of daily living, getting up, getting something in the refrigerator, making a sandwich. They don't feel tethered to the home and feel like they have to be there 24/7. They can go out and feel confident that their partner is able to be self-sufficient and function in a better way.
And I imagine it also just improves people's emotional well-being, because I know there was some questions about the impact on depression and apathy. And while that doesn't necessarily treat it, being able to feel better and to be able to do things certainly has a positive impact on mood. Have you seen that as the case?
Oh, without question. And when you're also talking about care partners, going back to my patient named Joe, just think about how that impacted his wife, the fact that she could get a good night's sleep as well.
Most definitely. And someone wanted to know about the success rate. And I'd actually like, if you're able to kind of compare success rate with DBS on things like sleep and just overall motor control related to like the best medical treatment. Do you have any information that you can explain to them, like how this can be successful in comparison?
So I think Meg kind of alluded to what I would describe as, indirect benefits, like the body discomfort resulting from rigidity that affects sleep. So by treating the rigidity, sleep improves. So some people will say like they have constipation, right? It's not going to help with constipation. Loss of smell is another early stage Parkinson's symptom. It's not going to help with that. So it is motor symptoms, but motor symptoms, just like the stigma of having Parkinson's and visibly having Parkinson's, depression can be impacted by better control of Parkinson's symptoms. It's not going to help the depression directly, but a lot of these. So when people start asking me, is it going to help with this? Is it going to help with that? My home base is always, do medications help with this? If not, then don't expect like freezing. Some people have freezing, and there's kind of two types of freezing we see. There's freezing that happens mid-stage that responds to medication, and there's later stage freezing that doesn't respond to medication. If it doesn't respond to medication, it's not going to respond to DBS either. If it does respond to medication, it's going to respond to DBS. So those are kind of like different motor symptoms that occur later. Same with balance. That's a later stage problem. The success rate, I would say, is at least 95%. I mean, we're not talking 1 out of 20 patients coming back following surgery saying, well, it didn't work for me. It is rare when somebody's like, well, I'm not one of the success stories. That's like less than once a year. Success depends upon the right diagnosis and safe and accurate surgery, right? We don't want surgical complications. We want to make sure that the lead is in the right place. Now, every surgeon is going to have in their record leads that could need to be repositioned because of side effects or not getting appropriate benefit. So that I would say, and maybe like once a year, I treat about 150, 170 patients a year. So it's less than 1%. I tell all my patients it will happen again, that it can happen to you. But so far as surgical success, you won't have successful control of your therapy if the lead is in the wrong place. And that'll happen with every surgeon. And for me, that's about 1%, less than 1%. Infection would be something where you have to go back and have the device taken out. That's less than 1 in 100 for me. Hardware problems where the device fails because the hardware breaks. We talked about that earlier. That's less than 1 in 100. And then, significant bleeds that result in permanent and significant deficits. That's also, those bad bleeds are less than 1%. I think for treating Parkinson's, if it's the right disease and the lead is placed in the right place, it will be 100% successful. So we're talking about things that are, these are things that are within my control, picking the right target and hitting it accurately. But if you actually have Parkinson's, this will have 100% success rate. If it's too early, then why subject yourself to even the smallest risk if you could just take medicine instead, right? If you do it too late, then you're just tackling the tip of the iceberg, controlling motor symptoms, and there's more advanced symptoms that are impacting quality of life. But when you look at all of Parkinson's, those motor symptoms, DBS will help with all of them. So there is a path to 100% success, and that requires appropriate diagnosis by the neurologist and safe and accurate surgery by the surgeon.
All right, so we had a question. Someone was offered DBS because their medication didn't help tremor. Is that something that you can address?
Yes, I always think of like tremor as kind of that exception, the caveat. Usually there's going to be like a little window where it improves, but no, if it's Parkinson's tremor or essential tremor, as long as it's not psychogenic tremor, which is tremor because somebody's kind of feeling their anxiety makes them want to shake and they feel better. So that's not a real motor deficit. Instead it's a psychological. No, but DBS will work above and beyond what medications do for Parkinson's tremor.
All right, so tell us a little bit about the assessment for eligibility for it. So I know some places have a team do an assessment. So it's not just the surgeon and the movement disorder specialist, but sometimes therapists will see them and neuropsychologists. Can you talk about why some places do that, what the benefit to that would be?
Yeah, I think part of the reason why the success rate is so high is because of the screening that goes in. And if anything, I think in the real world, having this high success rate reflects an inefficiency in how this therapy is actually delivered, because you put such high barriers to prevent a single failure that it's harder to get this accessible to more patients, because neurologists are booked out 3 months, right? So to get the neurologist time to kind of screen you for this, requiring it to take a village may make it less accessible in a timely manner to as many patients who stand to benefit from this therapy. Medicare says way more patients stand to benefit from this than who actually get it. And that means people are accepting a new normal that is not as good as it could be had you had the surgery. So the main things that we look at, the standards would be making sure you're an appropriate candidate. And that means, Meg, actually, you want to talk about the on-off test?
Sure. We want to make sure that you're still responsive to medications. And like Dr. Ponce talked about earlier, motor fluctuations. Your medication is still working, but you're taking more and more and more, but it's still working. So in order for us to evaluate that your medication is still working, we do something called on-off testing, which is you come into the office, you're off your medication, and we do, or your neurologist will do, a motor function exam. And you've all done this. Tapping the fingers, opening and closing the fist, getting up and down and walking. We look at your face, we look at your voice, all those things, and we score them. So 0 means the patient has no problem with this task. A 4 is the patient's symptoms are so severe they cannot perform that task. So we score this, we look at everything and score it, then have the patient take the medication, wait till it kicks in, and repeat this functional examination. And what we're looking for is a 30% improvement in your motor function score. That tells us that your medications are still working. Therefore, you are likely going to be a good candidate for DBS. However, like Dr. Ponce said earlier, the caveat is tremor. We all know that a lot of medications do not help with Parkinson's tremor. And then with essential tremor, that's a different ball of wax. But so we take that into account. So 30% is a guideline, more or less. So that is one part of the evaluation. Another part of the evaluation, which is very important, is a neuropsychological test. And what we're looking for there is that you have cognitive function. You have good cognitive function, good cognitive reserve. Because in our brains, we have what are called domains, different sections in your brain. It's kind of like a U-Haul storage locker, and each of those lockers is a different domain. One is for short-term memory, long-term memory, word finding, number recognition, all these different things in your brain, and you are tested for them. And basically this test, what we're looking for is to see whether or not you are on the road to dementia, you have serious clinical depression or anxiety. So if you have those 3, perhaps we will send you to a psychiatrist, get a little treatment. But if you're on the road to dementia, it's unlikely that we're going to be offering this therapy to you. So it's very important to get a neuropsychological exam, because Dr. Ponce and I, we are in healthcare, we're licensed, we take an oath, do no harm, and we do not want to harm a patient's brain. So we make our patients jump through these hoops to ensure that you are the proper candidate for this surgery. The other thing we look at with patients is not just physical and medication response. We look at your social situation, because this is a surgical procedure and you're going to need some assistance following surgery. And that is why many centers have a group together. It could be the social worker, it could be the nurse, it could be a therapist. Everybody sits together and discusses the patients to make sure you're a good candidate and that you're going to be safe after the surgery.
I find that insight in your condition is one of the best predictors to DBS success. If you're expecting something that I already know DBS isn't going to help with, well, you're going to be dissatisfied with the outcome. If you think it's going to clear up your thinking, which some people think, they're like, well, I'm hoping I can think more sharply. Like, no, that doesn't work. And part of this also, patients with good insight usually have neurologists who have educated them. So I've had patients who come in from kind of community neurologists say, I'm here because medications don't work. And they're like, it's not like they're shaking. They don't fit the caveat, but that's their experience. Like, they have not found medications. You should think of medications as like, unless you're that caveat of like the Parkinson's tremor, medication should be like your standard, like your point of reference. And I have patients come in, they're like, I'm here because medications don't work. And it's all of a sudden there's this mismatch in terms of what I'm accustomed to with my typical referral from neurology and what this one patient's reporting to me. And they're lacking insight. They don't know what part of Parkinson's bothers you, and I think the more you can define what Parkinson's means to you and what you're hoping to get out of DBS, the more likely you are to know what you're signing up for and be satisfied when you achieve it through surgery.
And most patients, when you go to buy a car, you're going to do your research. Well, I highly suggest you do your research and get as educated as possible before you determine that you're going to undergo DBS. Many centers like Barrow here offer DBS education classes. Also, there's a multitude of websites you can go on. You can go on a Medtronic. We have a wonderful website with a lot of information. It's called discoverdbs.com. And there's a wealth of information about the surgery, the outcomes, who's a good candidate for you to view.
Okay, so I know we're running out of time. I did have somebody that wanted to know if there is any impact on speech after DBS.
Patients have had speech difficulties following DBS surgery from time to time, and that is related to stimulation. It's not related to the surgery, because I want you to picture this. The lead is in the brain, and there's a little metal band called a contact, and we light up the contact with stimulation. And if you light it up and it keeps going out and around and around and around, and you put more stimulation, it could touch adjacent. Oh, I wish I had my picture with me. It could touch adjacent brain tissue, sending erratic messages to the speech center. So it's on stimulation. So there's many things the neurologist can do to help with those speech problems related to stimulation following surgery. And I have to tell you that with the Medtronic directional lead that's out, we can actually direct the stimulation to specific areas of the brain to avoid that kind of post-op stimulation complication.
And lastly, somebody wanted to know about adjusting the programming themselves. Is that something that this device will allow?
Yes. Patients go home with what's called a patient programmer, and you'll be taught in the neurologist's office how to use it. Now, initially, they may not want you to make those adjustments until you've gotten to that point where you're kind of smooth sailing with your stimulation. But what we can do is we can set parameters in there. And if you're home, and we all know that when you get a little anxious, perhaps your tremor will start to come out a little bit, you can make a small adjustment at home to dampen that down. There's many different things you can do with your patient programmer, and your neurologist can give you that ability to make self-adjustments at home.
Awesome. Well, we put the link up for that information, Discover DBS. So feel free to grab that. And if you want to save your chat, because I know sometimes it's hard to capture all those things. So everyone that is in the chat box, if you look over to the far right, there's 3 little dots there that says more. If you pop that up, you can save your chat. That way you'll have that link. We also on our website have a direct link into Medtronic, and the More You Know series also will explain some of these things in a short video, not to the degree that we've had today. So I want to thank Meg, and I want to thank Dr. Ponce, because this has been a great conversation and a different conversation that we traditionally have, kind of getting some, more quality of life aspects of, why is this a good choice for people? I want to give you an opportunity to like give one last plug or one last thing that you would like to share with everybody.
I think just like what you're all doing right now, it's never too early to start thinking about DBS. It's not a treatment of last resort. It's nothing new. It's not experimental. It's when we talk about 4 years of disease and 4 months of chasing symptoms, that's an early point at which to say, you know what, maybe I should consider this. So it's never too early to start talking to your doctor about this and making sure your doctor has a strategy and knows how to incorporate this in their practice, if not for you, at least that it's a tool, because it's one of the most standard tools after Cinemet for managing Parkinson's symptoms.
And I can tell you that from personal experience, from being in the world of DBS for over a decade, education, education, education. An informed consumer has a better outcome. So do your research, read everything you can, go on our website. I'm telling you, education is the key to a good outcome. And because when you go armed with that education to your provider's office, you can ask very, very good questions. And you'll go into this, like Dr. Ponce said, you know what you're signing up for, and you will have realistic expectations and good outcomes.
Awesome. Well, you guys have both been fantastic today in sharing your knowledge in a very understandable way. So one thing that you guys may or may not know about PMD Alliance is that we love to show our gratitude by everybody seeing you seeing us, and giving you the wave of gratitude. So I want to invite everybody, if you don't have your screens on, turn your screens on. Let's give Dr. Ponce and Meg a wave of gratitude. Thank you both so much for joining us today for this really great candid conversation. Thanks for all of you that joined us. Join us again. I think it's the 29th of this month. We're going to have the second part of this conversation, including someone who's had it. And we look forward to seeing you all then. Thank you very much.
Thank you.
Thank you for having us. Have a good day, everybody.
Bye.